and it's really great to be here. And as we start to get premenstrual dysphoric disorder research, I would say very much up and going and off the ground, and with University of Auckland being a real hub for it as well, I think this is a really timely talk to give as well. So yeah, I am Rachael Sumner. I am both a senior research fellow here with the Auckland Neuropsychopharmacology Research Group in the School of Pharmacy, but I am also now a senior lecturer down the road at AUT in their Department of Biomedicine and Medical Diagnostics. I'm a neuropharmacology researcher by trade. So I'm going to spend a bit of time defining what exactly premenstrual dysphoric disorder is. So something that's really important when contextualizing what it is that it was first given the term, the label formally and recognized within the sort of key textbook of mental health, the DSM, in 2013. So that's relatively recently that there was kind of a distinct label, premenstrual dysphoric disorder, provided. Okay. So within this, the table there takes the diagnostic criteria and says that you need to have 5 of the 11 symptoms listed there over the past year in general for most menstrual cycles. And the symptoms, at least one of them, needs to be rated as mild, moderate, and all the way up to severe. Now you have to have at least 5 of the 11 symptoms. This is really key. And it includes depressed mood, anxiety, tension, feeling like keyed up or edginess, affective lability. So that means mood swings. So major changes in mood. And that could be going from, feeling relatively well to all of a sudden feeling very angry, but it also could be feeling very irritable and then all of a sudden feeling very sad and very tearful. It's that kind of movement of emotions that gets into another symptom, out of control. So the other one is more of a anhedonia is the term that we use, decreased interest in usual activities. So maybe you like going to the gym, you like reading a book, you enjoy being with people, but during a certain phase of your menstrual cycle, you don't, right? And there's not a clear reason for that. Difficulty in concentrating, and that comes up in lots of different ways. It can be the ability to kind of, count out change or do some mental maths or maintain focus on a given task or even concentrate while somebody's talking to you in a conversation. Lack of energy, fatigue, maybe waking up and not feeling rested, knowing that you're rested but not feeling well. Change in appetite. And this allows it to go both ways. You might have cravings and want to eat a lot more food, or you might not be interested in food. A subjective sense of being overwhelmed or feeling out of control. And this might come into some of the other experiences like anger and irritability. I skipped past hypersomnia and insomnia. This allows, again, a positive and negative experience. You might want to sleep more, go to bed earlier than you've ever been. You might not feel like you can get up when your alarm goes off. But similarly, you might not be able to go to sleep. You might wake up at 4 a.m. and not be able to fall back to sleep. So both, so long as they're outside of your usual experience, is considered a symptom. And then the physical symptoms. And this is just one of the parts that puts it distinct to perhaps other mood disorders like an anxiety disorder or depressive disorder that you might be familiar with, that you have breast tenderness, headaches, joints or muscle pain, bloating, and weight gain. However, this isn't the only thing that puts it apart, PMDD, apart from disorders like major depressive disorder that are classified in the DSM, for example, or a generalized anxiety disorder, for example. One of the most important things, I think, a mistake that I made in the early days was I used to describe PMDD as being a disorder that's almost like a major depressive disorder, but it's only happening at one phase of the month. And the thing that made PMDD different was that it resolved during the follicular phase. And that was my own misunderstanding. And I think it's important to lock into, the more people you speak to with PMDD, that a lot of these are quite I almost want to use the word explosive emotions, right? We're talking about anxiety, tension, anger, irritability, these sorts of like overwhelm, out of control. People talk about impulsiveness. These are things that do seem to make PMDD sort of, I talk to neurologists and the term that they like to use is pathognomonic, the thing that makes it specific, not something that is just a version of a disorder that you've already heard before, okay? Now, in order to make it into a diagnostic manual, you have to fit all sorts of criteria around it. We might be familiar with major depressive disorder, where you have to meet certain criteria for 2 weeks. And if you don't have at least this criteria and not that criteria, then you don't have it. PMDD had to be the same. And I think this is really important that the researchers that were trying to get PMDD into the DSM knew this, and they said you had to have at least 5 of those different symptoms. So that gets you the formal definition of PMDD. I want you to see those 11 symptoms and see that you could have a severe version of at least one of those and not meet the criteria for PMDD. So you could have a reasonably severe mood change associated with your menstrual cycle that is interfering with your work, your school, your social activities, and your relationships, and yet not meet the criteria. So there's going to be a lot of people that don't meet the diagnostic formal criteria, but are still having a significant influence of their mood, of the menstrual cycle on their mood. The other thing that I want to bring attention to is that this is not just the ordinary experience of PMS. The reality is irritability and tearfulness are a reasonably normal experience of having a menstrual cycle, right? It's not universal, but it is considered normal. However, this is the kind of experience where it absolutely will influence your ability to be effective at work, your ability to be effective at school, your ability to socialize, and it usually shows itself most during relationships, okay? And so there are kind of other, I guess, ways that I want you to think about PMDD is that people could have a menstrual cycle related disorder that is essentially severe enough to warrant care, to warrant consideration, but you might not meet the strict diagnostic criteria of PMDD. Okay, so who is affected? Given that strict diagnostic criteria, 5 to 8% of females will meet that criteria, okay? So we can assume that a much larger proportion will likely meet the criteria for a menstrually related mood disorder you would have seen on that other slide. The other important thing is that the onset of the mood symptoms actually varies between people, okay? So there you can see the overlay of the sort of key hormones, progesterone and estradiol, when we think about mood and we think about the brain. More on that in a second. Now, the clear onset where it is considered PMDD or locked onto the menstrual cycle is at that peak of estrogen around ovulation, okay? Now, this is overlaid on the average menstrual cycle of 28 days length, but it's important not to overcomplicate that it's not halfway through the menstrual cycle that the onset of symptoms are. It's 14 days before the next period. So even if you have a 40-day menstrual cycle, PMDD will only start 14 days before, because ovulation will only occur 14 days before your next period, regardless of how much your cycle is varying, okay? So the key is that the onset is with ovulation, right? However, not all will have this experience. For some people, ovulation is relatively symptom-free, and then all of a sudden, it's like a cloud will come over like a storm within that last week, okay? Or there'll be a gradual niggling building that gets worse and worse and worse. And the worst phase in general is usually the week before menses onset. For some, with bleeding comes immediate parting of the clouds and clearing of the mood. And for some, it takes 1 to 3 days for that to happen, okay? But the thing that is key for PMDD is that the follicular phase is symptom-free, okay? That is the thing that makes us sure that it is not a worsening of a different mood disorder, So things that I like to think about is, does this mean that all PMDD is the same? Is it helpful to have a diagnostic criteria with 11 different symptoms where people must meet 5 of one and not the others and not have this? And then all those people have PMDD and we research them all the same and we treat them all the same? Or are these different sort of footprints of experience going to be important for how we treat people? And so this is relevant to me as a neuropharmacology researcher, because another thing I want you to think about when characterizing what PMDD is that it's not classically an endocrinological disorder. So a lot of people will get their blood tested. Very few people will have something in that blood test which indicates that they are having anything other than a healthy menstrual cycle. Okay? So their absolute levels of certain hormones like progesterone and estrogen will be healthy, and the ratio between those two will be healthy too. Despite this, because of that relationship to the onset of ovulation or other hormonal milestones of the luteal phase, it does have a very clear biological rationale. It has a clear biologically timed onset and a clear biologically timed offset. That is the thing that makes it PMDD and not something else. And the other thing that I think is relevant is to consider the PMDD within the context of other neurologically based changes over the menstrual cycle. So most with a menstrual cycle, with any comorbid disorder, will have a reasonably healthy experience. But you might not be familiar, for example, with if you have a menstrual cycle and migraines, for example. 20 to 25 will have menstrual migraine. So this is a worsening in migraine. It tends to be right before the onset of the period. But I don't know that that's not because there is ovulation-based migraine. I think that in general, people don't have a great understanding of when their ovulation is. That's changing with app tracking. But when it's not halfway, it's T-14. It's harder to find that relationship. Either way, menstrual migraine in general is classified as 3 days before, 3 days after the onset of menses. These generally tend to be a worsening of an existing migraine disorder, but they may be the only migraines you have. Especially if you're trying to prevent your migraine using other medications, they're often the ones that break through. The migraines that you still have, they're known to be particularly treatment resistant to preventative medication, particularly treatment resistant to triptan medication, and also particularly painful. There's also catamenial epilepsy. So this is for 40% of females with epilepsy. They will experience a worsening of their seizures. So like I'm saying, the normal experience of epilepsy and a menstrual cycle is not a worsening of seizures, right? However, there are a proportion of females who have a menstrual cycle and seizures, and they get worse. They have twice as many as they would usually have or more. For some of the people that have come through my research, it's the only seizures they have. Day one of their periods, guaranteed seizure, right? For some of them, they didn't know there was a relationship between their menstrual cycle and seizures because they didn't know when they were ovulating, but I could tell when they ovulated every single month for a year because there was a seizure. And this is interesting because it also has a similar incidence regardless of the type of epilepsy that people have. So you might not know much about epilepsy or you might know a whole load, but the point is you can either be born with it, you can have genetic changes, but you could also have a head injury and acquire it later, and you're still susceptible to catamenial epilepsy. So it is a change in the brain in response to the menstrual cycle that changes seizures. And I think that this experience of people with migraine and disorders like epilepsy can tell us about what these hormones can do to the brain that might also be important for mood. Okay? And something like premenstrual dysphoric disorder. Now, the other disorders I want you to be aware of is that, like major depressive disorder, I spend a bit of time discussing why we know that PMDD is not just major depressive disorder. It has different symptom profiles, but a worsening of your major depressive disorder at specific points of your menstrual cycle is also a recognized concern. I think it's plausible you could also have major depressive disorder and PMDD as a neurological concern on top, but that is going to be really difficult to tell the difference between. But you can have a recognized easing of your major depressive disorder during your follicular phase and worsening during your midlife phase. Bipolar disorder and schizophrenia. This often comes up as a worsening of psychotic symptoms during those disorders, or the really harmful manic type experiences and bipolar, but at that same specific time window, locked to T-14 or onwards, resolving within 1 to 3 days after the onset of bleeding. ADHD is another one, and there's actually a little bit of research there where if you change the drugs according to the menstrual cycle, then you can manage ADHD a little bit better. Eating disorders as well. So why might this be the case? Is there a biological rationale for the brain on reproductive steroids? One thing that I want to also make really clear is that we often characterize things like changes to the brain over the menstrual cycle as something that happens by accident. Reproduction is a primarily peripheral concern associated with the ovaries, associated with the uterus, and that hormones getting into the blood and making it their way into the brain and doing something pesky like making your migraines worse or your seizures worse or your mood worse is some kind of side effect, some unfortunate side effect of biology. That is not the case. These hormones, especially estrogen and progesterone, they are produced in the brain. They are so essential for brain function that the most studied region is the hippocampus, the absolute core of learning and memory in the brain, and it produces its own progesterone and estrogen, and it will change how it produces those based on things like stress. And in fact, most of the research on how the brain changes how it produces these steroids has been done in males. So the male brain produces these steroids in response to stress and injury. The brain will not only produce these hormones or change how much of those hormones are being produced, but it'll also change the rate at which they are being broken down in regions of the brain, which again speaks to the idea that whatever your brain is doing with these steroids might not be the same as what's coming out of your arm when you give a blood sample. And so the idea is that it's either a change in the way the brain is producing or breaking down these steroids, or it's just a change of plasticity in the way the brain is responding to these steroids. So, for example, if we come back to this hormone graph here, that you could say that if somebody had their onset of symptoms right at that peak of ovulation, you would say something about their sensitivity to estrogen. And that is a major sort of hypothesis that we work with, that there's a sensitivity to estrogen. But if your mood doesn't start to worsen until the few days before the onset of your cycle, it might be the rapid drop in progesterone that's the issue, or the rapid drop in estrogen. The fact that you had it at high levels for the last week and your brain got awfully used to that and then hasn't adapted properly to that being taken away so fast. Or if it doesn't start right after ovulation, but starts to build after that, then maybe it's actually that later peak in progesterone that's the pesky problem. We don't know yet. Somebody should study that. All right, so I mentioned before that 3 to 8% of people with a menstrual cycle will suffer from PMDD, but that is people who will meet the incredibly strict DSM criteria. And so we think that around 13 to 18% probably suffer from a clinically significant or something where I guess the biomedical interpretation could be of use, where they have some like irritability, dysphoric, anxiety-based symptoms that would be considered of concern associated with their menstrual cycle. So if we say 956 folk have premenstrual syndrome, so just PMS, then we say a proportion, I think that's about 25%, then a proportion of that in the millions are going to suffer from a clinically significant experience compared to 270 million people with depression. This is highly prevalent. Now, the other thing that I want to think about with impact is that each individual has around 459 cycles with about 6.1 days of PMS per cycle. This is people experiencing around 2,800 days of PMS symptoms. Break that down, that's 7 years spent. Okay? 7 years spent with a clinically relevant disorder. Okay, and we're talking about in the zone of number of people with depression experiencing 7 years of substantial symptoms. Now, part of, I think, the strictness of receiving a diagnosis of PMDD and how severe it has to be for you to get the diagnosis, but actually linked to this is, I think, how impulsive and irritable, and I talked about those kind of more explosive than passive mood symptoms being important. 72% of people that were diagnosed with PMDD report thoughts of suicide. 49% have planned a suicide attempt. 34 of those have made an attempt on their life. So this is a high risk mood disorder as well. So how do you get a diagnosis if you think this might be something that affects you? There's no blood test. Like I said, a lot of people want to get a blood test, and it can be encouraging to know that you're endocrinologically normal, because you probably will be. And perhaps if there is a disorder, then that is something that is easier to treat, you know, if there is a clear deficit or issue with one of the hormones, but the very real chances that there won't be any signature in your blood. However, there are things you can do. So you track usually for 2 cycles. So you complete a questionnaire asking about the severity of those 11 symptom domains and physical symptoms, and you track those over the cycle. And what's key is the resolution of the symptoms during the follicular phase and then that worsening at some phase in luteal. So I guess following on from endometriosis, the research as well is how hard it is to get a diagnosis. IAMPD, and I would recommend if you want more information, they're a really wonderful source. People waited on average 12 years to receive a diagnosis. And they had to see on average 6 different medical providers before they received that diagnosis. And so I think that we can say that for all of those statistics that I've given, we don't really know what the true epidemiology is. So I'm going to, my last section of this is to talk about what treatments there are. I'm going so well. Right. So one of the things that's interesting is that PMDD might be one of the clearest instantiations of the monoamine hypothesis of depression. So I don't know how many people are familiar with the idea of serotonin being at the center of depression. It's why most antidepressants given out work primarily or develop for their ability to work on serotonin. However, a lot of you will know that there are a lot of people who won't respond to antidepressants. They'll take the SSRIs, and I think it's about after trying 2, a third will find they don't respond to it. So there's been criticisms of the serotonin hypothesis of depression, that it's not the only explanation. But there's a pretty clear role between PMDD and estrogen, at least for, we think, a large number of people. I mentioned in that previous graph, there are reasons why we might think that some people might not have such a clear estrogen driver. But I'm not going to go into a full pharmacology. I probably traumatized you enough with that slide of cascades and things like that. But what I want you to see, these are my favorite types of figures where you might teach somebody about neurotransmission of the serotonin. It's coming out the end of one neuron, and it's changing the communication between that neuron at the top and something happening at the neuron on the bottom, right? And this is how we teach pharmacology and how serotonin changes like neuronal communication. You take those little blue dots, the little clusters of 3 there, right, with the gray arrows, those are all of the different research points at which estrogen has been found to affect how serotonin is regulating the brain. And we know that serotonin is really important for mood. Even if it's not important for everybody's mood disorder, everybody's depression, we know that if you mess with serotonin, you do mess with mood, right? And so those are all of the different paths in the cascade that we know that estrogen can influence how serotonin is treated in the brain. The other piece of information is that anybody that has tried SSRIs knows that it usually takes, 3 weeks, if there's going to be a response, for there to be a response. SSRIs, if they're going to work for somebody with PMDD, work a little bit more like painkillers. They tend to work within 14 hours. And this makes sense because those drugs increase serotonin in the brain within a few hours of you taking that first dose. So if changes in serotonin were important to the mood disorders, then that makes sense. Of course they would work on the day you gave them. And this does allow people to give SSRIs in the luteal phase only, and then stop taking them when the symptoms resolve, which is rather fascinating. And I think this tells us something about what happens in the brain. And there's been some fancy studies with brain scanners like positron emission tomography that have backed this up as well. So this is a graph down the bottom here. It was to do with one of the serotonin receptors, and it showed that in people without PMDD, there was a healthy change to serotonin receptors, the brain being plastic and upregulating and responding the way it should to the fact that we have much higher levels of estrogen than we usually have, that's changing our serotonin system in all of those ways. In PMDD, there was no change at all, which sounds like a problem in the functional response to the otherwise healthy changes in hormones. But unfortunately, and I promise I'll finish soon, the treatments, because of side effects, around half of people will discontinue SSRIs within 6 months, even if they were working. And a lot of those who stay on it are putting up with the side effects. 40% will have no clinical response, which means that we haven't completely solved it. So even though it's very compelling, there are other drugs that might be more useful. People try oral contraceptives, but the general thing is that they tend to be more effective for the physical symptoms than the mental symptoms. GnRH agonists, if you know about them, you probably know them most as puberty blockers. So they completely suppress the menstrual cycle, which can be really effective. But obviously that's quite an extreme option that is only appropriate for some people. Hormone replacement therapy, so bioidentical hormones, not for contraception, but for buffering the brain's response to the massive changes in hormones, are given, but there lacks a really clear guideline on how you're supposed to use them, at what dose, and who they're going to be useful for. So it's my belief that new treatments are desperately needed, that there are opportunities from the neurobiological underpinnings of PMDD to find these, but a new understanding of the treatments that we do have is needed too. So just finishing off PMDD in Aotearoa. So we can assume from all my statistics that I threw out there that around 62,000 people meet the diagnostic criteria of PMDD. 480,000 have PMS, and we know that a proportion of those are going to have a clinically relevant, essentially I'm going to say distressing, experience of mood changes over their menstrual cycle. And despite this, the Women's Health Strategy, which it's at least great to see a Women's Health Strategy coming out from the government in 2023, it didn't even mention PMDD once. So to fill that void, I'm really proud to introduce PMDD Aotearoa, a baby charity, but gosh, we're gaining steam and getting some real momentum going. It's a wonderful group to fill that gap in advocacy, in information, in action, in voice for people with PMDD. He wants me to stop. And thank you.
Well, thank you so much, Rachel. I have got so many questions for you at another time because my mind is whirling. It's incredible to hear so much about something that we don't know enough about. We just had a little something to say thank you is really a little something, but thank you so much for being here today and sharing this amazing work that you're doing. Such important conversations to be had. So
yes,
thank you for being here.
So thank you for having me.
No, it is our pleasure. Yeah, one round of applause. Okay, so now we have Courtney coming up for a quick fire spotlight. Your 3MT thesis, 5MT thesis. We have got your slide. Yeah, Alina will do it. She's the whiz.
My one slide. It's basically just so that you're not staring at my face the whole time. So.
There we go. Is that good? Let's see, making sure. Okay.
Just loaded the logo.
Yeah.
That's fine.
Well, let's see. Are you gonna just so are people on Zoom, or are you a roamer? Did you want the mic?
Oh, I'll just kind of stand here.
Yeah,
That way,
Okay.
yeah.
okay. I will stop the recording. How about that?